Welcome to this explainer. Today, we're diving straight into a massive topic that literally affects millions of patients worldwide. We're breaking down the true science of pain management, and more importantly, we're going to look directly at the hard clinical data to dismantle a myth that has shaped modern medicine for far too long.
So let's just start with the fundamental question that clinicians and patients wrestle with every single day. When you're dealing with moderate to severe pain, maybe it's chronic, maybe it's right after a surgery, what is actually the safest way to get some relief? Now, for decades, there's been this widespread assumption in the medical community. But as you're going to see in a minute, the data tells a completely different story.
Look at this definitive statement from recent clinical reviews. It says the historical perception of opioids as a safer alternative to NSAIDs for vulnerable patients is clinically unfounded. Basically, that long-standing belief that opioids are somehow the safer choice, it's a massive medical misconception. It's a real paradigm shifter, and it is actively changing medical guidelines across the globe right now.
To make sense of all this, here is our roadmap. We'll hit the great opioid myth, then measure real pain relief, look at the side effect spectrum, dive into the post-discharge danger, and finally wrap up with a new treatment paradigm.
Okay, starting right off with Section 1, the great opioid myth. So, for years, doctors were understandably worried about the risks of non-opioids, right? Your NSAIDs like standard ibuprofen. They were worried about predictable, localized risks, things like stomach bleeding or kidney strain, especially in older, more vulnerable adults. Because of that clinical hesitation, they often defaulted to opioids, just assuming they were gentler on the body as a whole. But the clinical facts now show us the exact opposite. While NSAIDs do carry those specific, localized risks, opioids trigger pervasive, whole-body physiological and psychological hazards. It's a totally different ballgame.
Which brings us to Section 2, measuring real pain relief.
You'd think, well, if opioids carry all these massive risks, they must be absolutely incredible at stopping pain, right? Actually, no. Take a look at the landmark 12-month SPACE trial. This followed veterans with moderate to severe chronic back pain or osteoarthritis, and the results are wild. After a full year, patients taking opioids actually ended up with a higher pain intensity severity score, a 4.0, compared to those on non-opioids, who scored a 3.5. Plus, their functional recovery wasn't any better either. Bottom line, opioids simply did not provide superior long-term relief.
And we have to talk about patient tolerability because it is a huge barrier here. Get this, a striking 21% of patients drop out of opioid trials entirely because the side effects are just intolerable. No way around it. And another 15% drop out because the medication fails to even relieve their pain. You combine those numbers and you're looking at a massive chunk of patients abandoning the treatment because it's either making them miserable or just flat out failing to work.
Let's dig deeper into that in Section 3, the side effect spectrum.
We really need to contrast how these two types of drugs function inside you. NSAIDs carry risks because they block enzymes that protect your stomach lining. Now that's a highly localized risk, like stomach irritation, and we know how to easily mitigate it. But opioids? They bind to receptors all over your body. It is literally a whole-body hijacking. We're talking about triggering everything from physical dependence to cognitive decline, dizziness, and even profound endocrine suppression.
Just look at the gastrointestinal system for a second. You know how people build a tolerance to the sedative effects of opioids? Well, patients do not build a tolerance to opioid-induced constipation. The drugs just continuously paralyze your enteric nervous system, completely slowing motility and triggering spasms. The data shows the number needed to harm is 7.1. To put that into perspective, for roughly every 7 patients treated, 1 is guaranteed to suffer severe constipation or nausea. We aren't talking about a mild upset stomach here. It's persistent systemic dysfunction. And this systemic hijacking, it goes even deeper. Chronic opioid use actually suppresses your central nervous system and your hormones. It's a condition called opioid-induced hypogonadism. What happens is the loss of testosterone and estrogen significantly reduces your bone density. That leads to a staggering 80% increase in overall bone fracture risk for patients on long-term therapy. 80%!
The weight of this systemic burden is so incredibly heavy that it directly impacts overall survival. The all-cause mortality rate for chronic pain patients on long-term opioids is approximately 1% per year. Now that might sound small, but that is roughly 5 times higher than for matched patients who aren't using these medications. The sheer systemic disruption dramatically increases the risk to the patient's life.
This brings us to a highly vulnerable scenario in Section 4, the post-discharge danger.
Consider a nationwide Medicare study that analyzed patients aged 65 and older right after they were discharged from the hospital. The findings were absolutely stark. Patients who filled an opioid prescription in that crucial first week faced significantly higher relative risks across the board compared to those taking NSAIDs. We're talking a 1.7 times higher relative risk of death, plus significantly higher risks for landing back in the emergency room, suffering falls, getting fractures, and dealing with severe gastrointestinal paralysis.
But hold on, because the most shocking takeaway from this study is right here. Remember that historical clinical hesitation we talked about earlier? The fear that NSAIDs would destroy a vulnerable patient's kidneys or cause terrible stomach bleeding? Well, in this nationwide Medicare cohort, those specific kidney and stomach bleeding risks occurred at the exact same rate in the opioid group as they did in the NSAID group. Think about that. The very reason doctors were prescribing opioids instead of NSAIDs turned out to be clinically unjustified for this population.
So, where do we go from here? Section 5. A new treatment paradigm. Given all this undeniable data, major medical societies have laid out a clean, actionable framework for how we should actually treat pain moving forward. Step 1 is implementing a multimodal, non-opioid default. That means making NSAIDs and acetaminophen your first line of defense. Step 2 is all about optimizing surgical pain relief, using targeted regional anesthetics like specific nerve blocks to drastically reduce the need for opioids in the first place. And Step 3? Personalize those non-opioids. Doctors can now carefully select the safest, specific NSAID to perfectly match each individual patient's unique risk profile.
Now, we absolutely must note the critical exceptions to this new paradigm. Palliative care, end-of-life care, and active cancer treatments are entirely exempt from these non-cancer pain guidelines. For those patients, the benefits of potent opioids still heavily outweigh the risks. Also, and this is absolutely crucial, anyone currently on long-term opioids must never stop abruptly. Going cold turkey triggers severe withdrawal and rebound pain. Instead, those patients must engage in a highly structured gradual taper, usually between 5 to 20% per month, always under close medical supervision. So, as we wrap up this explainer, I want to leave you with a provocative thought. Now that you know non-opioids actually offer equal or even better relief with far less systemic danger to your body, how are you going to approach your next conversation about pain management? The data makes it crystal clear. The safest path forward requires breaking old habits and asking much better questions. Thanks so much for joining me, and keep seeking the clarity hidden in the data.